Hello, everybody. Glad to be here. I want to go ahead and welcome everybody that is here. And before we get started with individual introductions, wanted to go ahead and present a brief land acknowledgement. I am a resident of Baltimore City, Maryland. I reside on the lands originally inhabited by the Piscataway and Susquehannock peoples. Baltimore remains home to the Piscataway, Lumbee, and an eastern band of Cherokee community members.
As a resident of Craig, Colorado, I want to acknowledge that I reside on the stolen lands originally inhabited by the Ute and Yampatika people.
As a resident of Brooklyn, New York, I would like to acknowledge that I reside on the traditional land of the Lamit people.
As a resident of Charlotte, North Carolina, I reside on colonized land traditionally belonging to the Catawba, Cheraw, Sugaree, Wateree, and Waxhaw peoples, all of whom have stewarded the land throughout the generations.
Thank you. And we would like to take a moment to pause, reflect, and honor those whose lands were taken and those who continue to experience systemic oppression as a result of the colonization of these lands. We'll continue to work towards showing respect for and helping those in need to the best of our ability.
Thank you. This portion of the segment, we would like to introduce the group members who are all doctoral social work degree students at Simmons University. My name is Leah Josiah.
And I'm Kevin Meenan.
I'm Melissa Almon.
And I'm Eileen Flores.
Thank you all. This part of this segment, we are honored to introduce our guest speakers who are experts in the field. We are going to start with Dr. Anna Newcomb. Can you introduce yourself to our audience and tell us a bit about what you do?
Yes, I am Anna Newcomb. I am currently performing as the trauma research manager at Inova Fairfax Hospital, which is very close to Washington, D.C. And I have a history of being a social worker. I still work as a social worker in the emergency department once or twice a month, and have done that for the last 25 or 30 years. And during the time that I was a social work intern and a social work social work case manager here in the trauma department in the 90s, I initiated a program called Rebuild, which was really a program of the survivor population who had asked me for some support in getting access to make a difference in healthcare, knowing what they know as trauma survivors and trauma families. So then that program, as I think many of you may have heard, morphed into a program called the Trauma Survivors Network, and that is a program of the American Trauma Society. And so over the last 25 years or so, Eileen and I and many, many others have worked hard to help trauma survivors across the country gain access to this program, which we'll probably talk about a bit more. I'm no longer terribly involved in it, although I sit on the board of the American Trauma Society, and I teach a course with others, Eileen included, so that other coordinators may be able to help patients gain access to this, and a variety of other activities that support the growth of this program. Oh, one of the things that I feel most interesting about my job is that really I do a lot of educating of trauma surgeons and nurses and other providers in the hospital, using trauma survivors as the educators in simulation. So the trauma survivors, along with some other staff members, are the actors who help trauma surgeons practice good relationship-focused communication. And my role is to teach the trauma survivors how to provide excellent feedback that provides some support to these trauma surgeons and other surgeons regarding how they should best approach patients and families in this challenging time.
Amazing, amazing. Now we would like to introduce Leah Litchfield. Can you introduce yourself to the audience and tell us a bit about what you do?
Yes, ma'am. My name is Leah Litchfield. I'm a person in long-term recovery. I'm a certified peer recovery specialist in the state of Maryland. I work for a company called Recovery Center of Maryland. I've been working in the behavioral health field for almost 4 years. I'd say as a peer, I mean, the word that always pops up is just advocate, 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 advocate. Our people have been looked over, quite often and, don't have a voice for themselves. So I take on some of that responsibility. It's very important to me. And just like basic needs, like that's what I focus on. Like, do you have food? Can we go get you food right now? Do you have clothes? Like, what is it that you need? Do you need to make a phone call? Do you have this? Do you have that? So that's about it.
Thank you so much. We are honored to have you both here today, especially to expound on some of this information that we're presenting in this podcast. Thank you. We would like to transition over to the agenda of this meeting.
So today, in this recorded podcast, we would like to do an overview. First of all, we'd like to define what peer support is and hear from our guest speakers, our experts on that definition as they apply it. We also wanted to discuss what are the challenges and what are the barriers to peer support, and just to hear a little more about what to consider in how peer support can be better supported by professionals moving forward throughout healthcare and throughout community services. So, and then we'll go to a closing and that'll be it. And now I'm going to hand it over to Melissa as we talk a little bit more in our first section.
Perfect. Thank you, Eileen. So now that we've met our panel and we've gone over today's agenda, let's start by defining peer support, gaining a better understanding of its importance. And the way that we're going to do that is through discussing what's been found in the literature and then hearing from our wonderful experts. So peer support has been defined by SAMHSA as a system of giving and receiving non-clinical support based upon the principle of shared experiences, responsibility, and cooperation. Crossbeck and colleagues add to that, stating that peers provide the following benefits. They fill a role as a staff member facilitating hope. They function as staff members bridging the world of the mental health care facilities and daily living, interactions of daily living. And they help promote a culture of anti-stigma, right? They are maybe more aware of the appropriate languages to be used with our clients. And just by attending interdepartmental meetings, they maybe help raise an awareness amongst colleagues of how to speak respectfully about the staff and clients that maybe have a history of substance use or other issues that are often stigmatized. Furthermore, Wilson and colleagues add that peer programs engage and provide services to members of the agency's target population, and they lend credibility to the agencies. And so what this can do is it can help reach clients that may not otherwise have come into that organization for services, just by having someone there that maybe can connect a little bit better with what they're being seen for. So after hearing this information from the literature, I would like to ask Leah Litchfield, from your own experiences working with people in substance use, why do you feel that peer support is so important to recovery?
I think it's so important because, like for me, as an example, when I first got clean, like being helped by someone else that had been through what I had been through, some of the extremely shameful experiences, it helped me. It gave me hope that there was a way out, and I really did trust them when they told me that I could do it, and so. I think the connection that we have, like it's just it's different.
Thank you so much for that, Leah. I have some more research here from our literature base as it relates to survivors of traumatic injury. One of the studies, who I believe Dr. Newcomb also co-authored, Castillo et al. In 2013, did a study with trauma survivors. And as they were involved in the Trauma Survivors Network support groups and other peer support services, and they found that 54% lower odds of depression as defined by the PHQ-9 as compared to survivors who did not receive those TSN peer support services. And then there was another study from an actual site in Cleveland, Ohio, Simsky et al. In 2019, studied the impact of the Trauma Survivors Network at their Level 1 Trauma Center over the first 5 years of implementation. And the authors found that the trauma patients who were exposed to the TSN peer support services reported higher self-efficacy in their likelihood of recovery and their return to daily activities. So I'd like to ask this question of Dr. Newcomb. Dr. Newcomb, from your experience working with and developing services for the Trauma Survivors Network and the research, why do you feel that peer support is important to the healing process?
It seems like Leah has already kind of touched on all of the parts of that. And one of the things she said is that the connection is really different between peers and regular staff members. I'm a pretty effective social worker, but if I haven't been through something that is in any way related to what my patient or my clients or my community member has been through, it's really hard for me to do what Leah was talking about, and that's build trust. I mean, they can trust me because I seem trustworthy, but I don't have the same shared history. And so when we are able to connect folks who have had this traumatic experience or an experience of addiction or whatever it might be that's really specific to that population, we are able to give the sense of, or we're able to work against the sense of isolation. Because one of the things that, well, Leah also talked about this, the shameful experience of whatever it is that we've been through, that experience isolates us and it makes us feel like we shouldn't be talking about this. We shouldn't be going through this, and we're not even worthy of trying to get help. And when somebody who comes into your room or comes into your life who has been through this, they can fight against that shame feeling. They can help you understand that you're absolutely not alone, that you're not this, you are a part of a community that is wanting you to be well. And that whole stigma thing, I know, Melissa, you talked about the process of reducing stigma. Stigma is what makes us not want to go out and find others and be connected and get help and then help others. The other thing that I think is really important about peer support is that when we ask a peer to help, we are asking them for something that only they know, that the expertise that they have worked really hard to get, and that is recovery. So when we ask them for help, we are seeing them for their strength and not for their disability. And when we see them for their strength, they are that strong person to somebody who needs to have that hope or that sense of possibility that Leah talked about. So there's just a whole lot more that's available to a newly injured or a newly suffering person from somebody who has lived recovery that's not possible from like a really nice social worker, because there is this whole community that opens up to them, that is welcoming and warm and hopeful, that like a clinician can't really offer.
Thank you so much for both of you for your answers. And I'm going to pass the baton now to Leah and Kevin for our next section.
Yes. So we spoke about a lot of challenges in the very beginning. Thank you, Leah and Dr. Anna. But in my research, I have found many areas of challenges as it relates to peer support. One main thing that stood out to me was the perpetuation of the stigmatization, as we mentioned, and discrimination as it relates to self-disclosure, which can create inequalities in employment statuses as well as lack of credibility. And that's from Scandal 2021. My question is for Leah Litchfield, and it's related to peer supports. As a peer support specialist, what are you looking for in a mentor? How can they support you in the workplace? And what does a recovery-oriented workplace look like for you?
Okay, you might have to ask me the second half of the question again.
I know it's a pretty loaded question.
But the first half, for me, someone who is open-minded, someone who is well-versed on, what peers are here to do, what the guidelines are for whatever state you're in. What else is really important? Professionalism. That can be lacking across the board. That can be a major issue with some of the people that hold the same title as me. So I'm really just making something up here because I've never had a true peer supervisor. I've worked for the health department. I work here. I worked in an inpatient treatment center, and I luckily, could gather information here and there, and I think that I do a really good job, but I have lacked a mentor, and I would very much value one. And what was the other part of the question?
Okay. How can they support you? So if you in the workplace, what would you look, so if you wanted a great mentor, what would that look like for you, and how can they support you in the workforce?
A leader, somebody that's strong-willed, somebody that, all the things that I said before, somebody that's open-minded, professional, somebody that I can learn some things from, I still can learn from, everyone that I work with, the clinicians, the non-clinicians, but to have someone to work with would be really cool.
Mm-hmm. That sounds great. Thank you.
Thank you. I want to bring up a few more research-based pieces of information, but actually they kind of piggyback off of what Dr. Newcomb and what Leah had already said. One of the things was in an article by Forbes and colleagues indicating that respect and a non-judgmental attitude were important in non-peer supervisors that are supervising peer support specialists. Acceptance of the peer support professional on the team, and also some type of clear role definition and clarity were also noted as very important. However, what tends to happen, according to research by Furman and colleagues, is that despite the statements that a peer support specialist is here for advocacy and hope and empowerment, oftentimes as a peer support specialist, they experience overt stigma, and sometimes this can be in the form of team meetings. When a group of professionals is together behind closed doors, sometimes the language concerning clients can be pretty offensive, specifically for people who have experienced, whether it's substance use disorder or as a trauma survivor or someone dealing with mental illness. And so that overt form of stigma can be really disheartening and kind of bringing you down a notch. But also the covert stigma, right? Like microaggressions. And some of those microaggressions might come in just the form of, talking about them, right? Or talking about the fact that, they're in a program, right? And they're in a program, so they have to do this, right? And someone who has experienced that might experience that as something of, that's pretty stigmatizing. So, the idea that, and Leah, you spoke to this lack of formal job, description or lack of formal, specifically trained leadership as a peer, when there is no when there is no specific job description or no specific guidelines, integrating peer support can be really challenging. So this next question, kind of summing up this idea of helping the entire team get on a page of recognizing overt and covert stigmatization, as well as development of job guidelines. Dr. Newcomb, what do you feel has been or could be some of the biggest challenges and barriers to development of a program of peer support services?
I think you already kind of mentioned a lot of it, Kevin. I think there's this sense among healthcare that there's them, you mentioned that, there's them, those people who need help. And then there's us who are like above those kind of people. And when we bring those people into our team meeting, very often the providers, I notice, are well behaved at that time. When they're in the presence of the thems, they are sort of their grown-up selves, they're their professional selves, but when they are in a meeting without the peers, they may revert back to the other language. And so I am personally remembering being a social worker being a new social worker on a team in a nurse's station, being responsible for making sure that these patients are getting what they need. As a new young social worker, I noticed that the culture at the time was really to depersonalize the experiences of the patients and the family members, and to have a language that wasn't respectful, was judgmental, and wasn't really accepting of their role. And I had been through social work school, so I knew the way we were supposed to approach it. But I also was a new professional. And so I felt like what I needed to do was really be a good joiner of the team. And I remember very clearly sitting at a nurse's station at one point and making some comment about, those people in 39. Maybe just like that. And that's the room numbers, not their name. It's just like, oh, those people. And there was a physician next to me who I highly value, kind of late in his career, and an old white man who said to me, "Anna, you're better than that." And it just stopped me in my tracks. I was like, I am better than that. I don't know what happened to me that I would be using this. I mean, it wasn't much. It doesn't matter. The intent was clear. So I sense that, and I have since then tried very hard to be the Dr. Barrick for other people in every meeting. So my commitment is to keep that feeling every time I have a meeting with anybody else, to always sense that people want to be their best selves, and that sometimes the culture and the environment asks of them to demean others. And so all I can say is what I want to do, and what I commit myself to doing, and I'm not perfect at it, is to call it out gently and respectfully when I see these microaggressions or this oppression happening, because it is something that's happening in the culture. There are all sorts of reasons, burnout, whatever. But I think one of the ways that we can work with it is to be the person who we wish would be in the room. And what I notice is that people are very hesitant to say those things in my presence. They may be saying it elsewhere, but so then I'm always trying to be in meetings, because I know that they're thinking about it when I'm in their presence, because I've been teaching them these classes and I've been making these comments. And that's like the best I can do, is just be the person that you wish that everyone would be, and then hope that they reflect on that when they're saying something inappropriate, and that their grown-up selves kind of clicks in every so often.
Thank you. I like that concept of joining the team, right, and modeling appropriateness. So thank you so much. Melissa, I was going to hand it back over to you, talking about how we can maybe better support our peer support specialists.
Absolutely. So now that we've taken the time to understand kind of what the challenges and the barriers are within peer services, let's look at some different ways that we can help support peer support and better support our peer workers. So going back to the literature again, Mamdani and colleagues state that there's a critical need for support for peer workers that recognizes the unique positions that people with lived experiences bring to the table in the professional setting. So there's a lot of challenges that come with working in an overdose response environment or a trauma environment. And although peer work has multiple benefits for our service users and even employees, it can be really stressful, have lasting emotional impacts and mental health impacts. Wilson and colleagues further added that if programming for peers isn't carefully implemented and peers don't feel supported, they may experience negative consequences such as burnout, feelings of exploitation and stigma. And so I would like to ask either of our wonderful experts, what are some of the ways that you feel that peer programs can be more successfully implemented in the workforce, and how can they better be supported by their colleagues?
Well, I think that safety should be like at the forefront. I've been asked to go several places, throughout my career that I definitely, looking back, I know that I shouldn't have gone alone. But mainly the just having the awareness of, like the core values of a peer, or just really, like I said, the state's guidelines is very valuable.
It seems that it's really difficult for a peer, at least in the trauma world, which a peer would be a former patient. It would be pretty impossible for them to gain access to those current survivors, those current patients, without an insider. So it's important that the insider, the staff member, be that person who is all of those things you wish they would be: accepting, respectful, able to provide guidance and provide mentorship. But I think one of the things that's really important for the institution is that they're clear what those good guidelines would be. They're clear what the how that role is defined, and they're very clear that that peer is being cared for in a way that gives them the support for this emotional work that they're doing. So in the TSN world, or in the hospital world, we need to demonstrate that we have a really clear way of training these people and supporting them. So training is like a moment in time, but all of the work that they do as peers is different than a clinical person providing the support, because it is ongoingly and triggering their memories of that time for themselves. So we need, as coordinators or providers or supporters of those peers, we need to, every time that they're having their work done, that we need to be able to make sure to check in with them, make sure that they're still doing okay, because there's no work that's harder than supporting somebody through something that you've been through. And if we don't kind of give them, if we don't institutionalize how we do that, they will more than likely find this to be really challenging and will not be able to continue to be that support for the new folks.
Thank you both for those comments and for your insights and expertise. So we are just about out of time, and this has been such a great conversation all around. I want to give a special thanks to Ms. Leah Litchfield and Dr. Anna Newcomb for joining us today as our experts. And we also want to give a special thanks to all of our listeners, our classmates and our professor for listening and joining with us today. Thank you so much.